It's great to have the opportunity to spend a little bit of time with everyone. I thought Adelina said it perfectly. There's such opportunities with COVID. It obviously was devastating for long-term care systems around the world, but following the pandemic, there's a real opportunity for cross-country learning. How do we change the structure of our long-term care systems? And the focus of today's presentation, how do we think about regulatory approaches? So I'd really like to do two things with my time today. First, I want to kind of review the impact of the pandemic, where the U.S. nursing home sector stands today, and then talk about some of the approaches that we're seeing in terms of increased regulation within this sector. And as a kind of a spoiler alert, some of the regulations are very focused and I think a direct result of what happened in the pandemic. Others are very disconnected from what happened in the pandemic. And so you'll see, and hopefully there are some lessons for other countries. And I look forward to questions and comments and learning about what's happening around the globe. So I want to start with a quote, and I really believe this is really kind of sums up what happened in the U.S. I was part of a National Academies Commission here in the U.S. that studied nursing homes broadly in terms of how they're paid, how they're regulated, how care is delivered. And it's a 600-page report, but the best line came from not one of the authors like myself, but rather from this daughter and caregiver of two parents with dementia who were requiring nursing home care. And she stated, "The pandemic has lifted the veil on what has been an invisible social ill for decades. Thankfully, I think the pandemic drew a lot of attention. We can debate whether that attention has stayed on nursing homes here in the US. I don't believe it has, or if it has, it hasn't always stayed on nursing homes in, I think, the most productive way. But it most certainly, the pandemic lifted the veil." And what did that look like? And I'm just going to run through some slides here to kind of review what happened here in the U.S. in nursing homes. Just to start with a timeline, going back to March 2020 and then up till this month. And you can see there in blue and red, COVID cases among nursing home residents and staff members. And then in black, you can see resident deaths. And early on in the pandemic, when we saw a spike in cases, we saw a corresponding spike in mortality. Thankfully, many of our residents and staff are now vaccinated. We're having challenges here in the US in terms of booster shots. Not everybody is up to date, but the good news, and I know this isn't exactly drawn to scale, so the death rate among residents is not zero today, but it's much lower than it was early on in the pandemic. That said, we've had over 2 million cases among residents of COVID. To give you a benchmark, at any given time, there's about 1.3 million individuals in US nursing homes. So this is a big number relative to the steady state population. And then we've lost almost 189,000 individuals to COVID. Many people ask me about excess mortality, like, geez, these are older adults. We know that the death rate is already high in nursing homes. This was a calculation just in 2020 of excess mortality. The death rate was up by a third in just that year alone, and an additional 170,000 deaths. Why is this so much higher than the prior slide? This encompasses both deaths due to COVID, but also deaths due to other factors. Turns out the pandemic was really challenging for nursing home residents, not just because of COVID, but because they were isolated and alone. And you can see this in these survey data that were taken back in October of 2020, where they asked residents at that time, were you allowed to have visitors, outside activity, enjoy fresh air, communal activities, eat in a dining room? And you can see things that we all take for granted every day. We saw a major decline during the pandemic. One of the things that I find really alarming about this is that these rates weren't 100% before the pandemic. And that's suggestive that U.S. nursing home sector has, that's that sort of social ills that have been going on for decades that the family member mentioned earlier. We've had a longstanding crisis in the U.S., and the fact that only 58% could enjoy outside activity or 68% could go eat in a dining room is really telling. These should be much closer to 100%. This is a piece we published in JAMA back in 2022. And the point of this piece was that the pandemic wasn't just hard in terms of COVID, but also hard even in facilities on the right-hand side here that never had an outbreak. And you can see we saw weight loss and a spike in depression, even in facilities that never had an outbreak. So we know in facilities on the left with an outbreak, things were pretty dire, but things were bad even in facilities without an outbreak due to isolation and loneliness. What about just occupancy rates in U.S. nursing homes? This is just benchmarks. This is from the MedPAC report earlier this month. You can see that pre-pandemic median occupancy, that's that line there, the 85%. We were pretty low back in the end of 2020, 2021. Median occupancy was below 70%. It's climbed back up, and by August of this past year was up at 81%. So we're slowly climbing back, but it's been a slow recovery. And I do think there's a group of individuals that still don't want to go to nursing homes in this country. And I guess I should amend that to say nobody has ever wanted to go to nursing homes in this country, but they're willing to either have family members do that care or pay out of pocket for other sources to keep their loved ones out of a nursing home. What about staffing? And you can see that sometimes you need to label what happened on a graph. You can see that the U.S. Nursing home was growing in terms of staff. It was up almost to 3.4 million staff members in early 2020, and then we had that precipitous drop, ultimately losing over 400,000 workers in this sector. It's come back a lot, just like occupancy, but it's got a long way to go to reach that pre-pandemic level. So we're still down 144,000 workers relative to the start of the pandemic. I think the title of this slide is probably an understatement. I think we undervalued U.S. Nursing home staff tremendously during the pandemic. We saw huge shortfalls during outbreaks, COVID outbreaks in nursing homes, and then following those outbreaks, we did a paper just showing that once an outbreak happened, a number of staff left the workforce and had to stay out due to COVID. We also had work early in the pandemic showing that we failed to support them in terms of personal protective equipment. We gave them very limited access to rapid testing. And indeed, that was an early paper we did. In a later paper, my colleagues showed that access to rapid testing or lack of access to rapid testing led to increased resident mortality. So that cost us lives by not going in and testing for COVID in a sort of a comprehensive and rapid manner. And then finally, we lost a lot of lives in terms of staff members as well. We did a piece that we published. It was an op-ed to try to get as many eyes on it as possible in the Washington Post, titled Nursing Home Staff, the Most Dangerous Job in America. So newspapers in the US will often rank the most dangerous jobs, and typically they're construction or commercial fishermen. In 2020, working in a nursing home was the most dangerous job in America. One of the outgrowths, and this is a piece we just published earlier this year in Health Affairs, is that nursing homes are still struggling in the US to find full-time staff. And so they have had to turn to what we call agency or contract staff. And you can see prior to the pandemic, about 3% of staff in nursing homes were agency staff. And since the pandemic, that's up around 11, 12%. So a large growth in the use of these agency staff. Lots of research suggesting consistent staffing is going to lead to better quality for our residents. And also in terms of the pandemic, there was some great research suggesting that the more consistent your staff, the fewer bodies in and out of the building, the less COVID would spread to these facilities. So this isn't good for infection control, and this isn't good for care quality. One other point I wanted to make on staff was just about the importance of foreign-born staff in the U.S. We're having a big immigration debate right now in the U.S. as other countries are around the globe. And foreign-born workers in this country really bailed us out during the pandemic. We saw a big decline in native-born staff to the extent that we saw individuals leaving, and that really predates the pandemic, but it was really driven by native-born staff leaving the workforce. Foreign-born staff really stuck it out. And we have another paper showing just the importance of immigrant staff members for the supply of staff, but also for staff outcomes. So going forward, and I know this is true around the globe, foreign-born staff, foreign-born workers are going to be really important, and they have been an important part, and we need to support that. And I'll say very quickly, this isn't instead of everything else like raising pay, working conditions, benefits, et cetera. This is in addition to, but this needs to be part of growing the long-term care workforce moving forward. So final slide on kind of COVID before I pivot into thinking a little bit about regulation. We wrote a paper, Brian McGarry and myself, back in 2022, and we borrowed a line from my colleague Barb Bowers, who said, COVID is a crisis on top of a crisis in nursing homes. The short-term crisis was obviously COVID and the pandemic, and we've been discussing, but lots of cases leading to far too many deaths, residents being isolated and lonely in their rooms, caregiver shortages, workers having the most dangerous job in America, declining occupancy. That's the short-term crisis, but we laid that on top of a longer-term crisis where we have low Medicaid payment rates. So Medicaid is the dominant payer of nursing home services in the U.S. Lots of instances of poor quality, low staffing, low pay for workers, big disparities in terms of race and ethnicity across facilities. Our nursing homes are too big. They rarely have single occupancy rooms. They have shared rooms, 100-bed facilities. We're going to talk more about this in a moment. We have a very ineffective regulatory model here in the U.S. We'll also talk about these last 2 points. We have a lack of quality and financial transparency. We have an incredibly fragmented ownership models in this country. So if we're going to fix nursing homes, we don't just need to address what happened during COVID, but also address some of these foundational issues as well. What is happening in the U.S. Back in 2022, with that veil being lifted, finally, a U.S. president made nursing homes a focus. Nursing homes have been largely an ignored policy issue in this country. It rarely comes up in presidential debates. It rarely comes up in State of the Union addresses or other presidential platforms. I'll give President Biden credit. He did discuss nursing homes as part of a State of the Union address to the country and to Congress. And then he released a platform of reforms that really had 3 parts. First, he introduced a federal minimum staffing standard. Second, he called for better financial and ownership transparency. And finally, he called for increased quality accountability. Let me talk through each of those issues, where the U.S. stands, what we're doing, and how we're kind of responding to what we saw during COVID. So as I noted earlier, when it comes to minimum staffing, this has been a longstanding issue that predated the pandemic. So this was a paper that we did back in 2019, just showing most facilities on most days in the U.S. are below the acuity adjusted expectation that the federal government puts forward. That's an expectation. This is just like what you should have based on who's receiving services in your home. It's not mandated. It's just this is what you should, this is the number of staff that should be on site. The vast majority of the time, facilities are below this expected level. And we saw during the pandemic that when outbreaks happened, staff left the facility. They weren't there during the recovery. We needed better working conditions in nursing homes. So many US states have minimum staffing standards, but currently at the federal level, the only rule is that nursing homes must staff at a level that ensures resident safety and well-being. And they are supposed to have an RN, a registered nurse, or licensed practical nurse, LPN, present in the facility at all times. Now, towards the first rule, that may sound like great. You're supposed to staff at a level that's safe and encourages well-being of the residents, but that's way too loose, and facilities are left to interpret it however they might interpret it. So what's this new rule? And my understanding is it's currently in front of the Office of Management and Budget, and we don't yet know what the final rule is going to look like. But the proposed rule that the Biden administration put forward is that every facility must have roughly a half hour of registered nurse time each day per resident day, and roughly 2.5 hours of certified nurse aide time per resident day. They made no requirements about licensed practical nurses. So in the US, we have RNs, LPNs, and nurse aides. The new rule would have a requirement around RNs and a requirement around certified nurse aides who do the bulk of the direct care, but no requirement around LPNs. An RN would be required 24/7. You can no longer have an LPN to meet that requirement. And given the perception that this was going to be very challenging for a lot of US nursing homes, there were some aspects of the rule that have tried to give nursing homes some relief. So they built in some exemptions based on local labor market conditions. If nursing homes can't find available workers, then you're exempt from the rule. They have a very slow implementation period of 3 to 5 years. And they also built in some money to train workers. So this is not money to pay workers. This is money to help train the next generation of workers. We did a quick and dirty kind of check of how many facilities nationally would meet this based on data from last year. And you can see that it really varies across US states. There's some states like Alaska, which has very few nursing homes, by the way, like maybe 6, but all 6 nursing homes in Alaska would meet the requirement. Over on the right, Oklahoma, Texas, Louisiana, very few nursing homes are currently in compliance with these RN and CNA rules. Nationally, about 1 in 5 facilities currently meet the threshold. I published a piece in the New England Journal of Medicine with my colleague John Boblis, where we argued this is an incredibly important rule, arguably the most important nursing home reform in decades in the US, because finally it's going to require a minimum number of staff in US nursing homes. But there's also some gaps. And so we tried to make some suggestions as CMS and the federal government here in the US moves towards a final rule. So first, we argued that they came up with a level for RNs and they came up with a level for CNAs, but they basically exempted LPNs. They didn't really say anything about the overall level of staff in the building. So in theory, 3 hours per resident day when you add up RNs and CNAs, but that's really low. And we also didn't like the idea that LPNs were left out. We're a little bit worried that nursing homes are basically going to stop using LPNs in the production of care. We worried a lot about the exemptions from the rule in local labor market conditions. This suggested to us that we have broader payment failures in the US. If we're not paying nursing homes enough to staff their facilities appropriately, given local labor market conditions, that's not a staffing problem, that's a payment problem. And we also believe that, going back to the prior slide, there's some markets and areas that are close to already meeting the requirement. Why are we waiting 3 to 5 years to implement this? And finally, we hope that this was the beginning of a set of reforms, not the end. There's a lot to be done in U.S. nursing homes, including reforming how we pay and finance for care. So that's some thoughts on staffing, and I'm going to come back to staffing in a moment, but I wanted to turn to the second reform that the Biden administration has put out, and that's improving financial and ownership transparency. Uh, I was talking to Adelina before we started, and I was a little worried this part might just be a US phenomenon, that we have really complicated ownership structures. And she assured me that this is present in the UK, it's present in Spain, I understand. I know there are other countries that I've talked to as well. So if your country doesn't have this feature, congratulations, you have a better system than we do. But I think many of us suffer from this, that ownership went from this single owner-operated entity that was relatively straightforward to one that's very complicated. You can see there, the Attorney General of New York tried to map out how all these payments work for a given nursing home in New York State. And you can see all the lines there and how complicated this gets. And the concern here, why do we care about this, is that dollars are getting moved away from direct care and aren't getting put into direct care, and they're getting paid into monitoring fees, lease payments, interest payments that are excessive. And basically, nursing homes are hiding or tunneling profits. And indeed, there's a paper by Gupta and colleagues back in 2020 that showed that once U.S. nursing homes are acquired by a private equity company, there's an increase in all of these mechanisms, monitoring fees, lease payments, interest payments, that move money in the U.S. away from the delivery of care and towards the pockets of these owners of these facilities. The Biden administration has tried to improve the transparency. We need to understand who owns this, who owns these facilities. We're going to figure out how they're using our money. And so there's been a series, and I won't read this to you, but we now have data on mergers and acquisitions and change of ownership. We have data on common ownership. Some of our federal report cards are including affiliated entity names and IDs and performance measures, where this is available to individuals looking to choose a nursing home. And then finally, we're going to have information on private equity and real estate investment trusts that are going to be disclosed. So that's a big development. We, in a recent paper led by a doctoral student here, Amanda Chen, that we just published in Health Affairs, we wanted to see whether the current Biden administration data, the data that have been released, are actually capturing most private equity and what we call real estate investment trusts deals in the US. So we went ahead and collected proprietary data and compared them against the data that was being released. CMS is just the Centers for Medicare and Medicaid Services. That's the federal government. And we found that the federal government data didn't perform very well. We could only find about a third of those nursing homes that were acquired by private equity companies, and less than 1/5 of the nursing homes associated with real estate investment trusts. So the current data, and as I said on the prior slide, more is coming. They're trying to improve these measures, but at least today, the data that are on the website are incomplete. We went on in this paper to look at a couple of other variables to see just how well the data are performing. A number of nursing homes weren't reporting their ownership percentage, so we really didn't know who owns these facilities. And for the top 10 chains, over 80% of owners did not report an ownership percentage. So that's really disheartening, that although we're investing in data here in the US, we're not really seeing everything that we need to see about who owns these facilities. Why do we care, once again, about who owns these facilities? It's because if you have these complicated ownership structures, there's the possibility of tunneling or hiding profits. And this is a brand new a National Bureau of Economic Research, or NBR, working paper, and I've got the URL there at the bottom, but Ashvin Gandhi and Andrew Alinsky actually were able to study this. So here in the US, we're not able with our federal cost reports to track all the movement of the dollars across these related party transactions to see, like, if I set up a management firm or I set up a lease company and I pay them an above market rate, I can hide money over there, make my margin look worse, make it look like I'm losing money when in fact I'm actually making a lot more in profits. So they study this tunneling of profits, and I'd encourage you to kind of take a look at this paper because I really like it. But they use data. One state in the U.S., Illinois, has really good data, and they were able to leverage the Illinois data to study this. And I'm just blown away by this, that they suggest, based on the Illinois data, that 63% of profits are hidden through these related party transactions by inflated transfer prices. So there's nothing in theory wrong with having, your own lease company or management company. The problem becomes where you pay these exorbitant rates, above market rates, to hide profits. And we're seeing quite a bit of that in the US. I wrote it, and if I could have written it even bigger there on the bottom of the slide, I would have, because this is so important. We need better data on who owns our nursing homes in the US and how they're spending public dollars. And I think one of the big takeaways from Ashvin and Andrew's paper is that we need to invest in better federal cost report data here in the US. What Illinois has for that state is, we should have nationally, because this is going on everywhere in the US. And I just wanted to connect the first two issues here, the minimum staffing standard and this emphasis on investing in better financial and ownership transparency data. Once again, we're stuck here in the US in terms of minimum staffing. We're sort of mired in this huge debate. On the one side, industry members are telling us that this is an unfunded mandate. There's not sufficient money in the system. On the other hand, on the other side, advocates are telling us there is sufficient money in the system. There's just a lot of it being tunneled into related party transactions. We don't know who's right here, and we don't know that there's a common set of facts that both sides are working from. So if we invest in better data, and this was the point of an op-ed I did with my colleague David Stevenson, we published this last month in Stat, and we said that everybody knows we need minimum staffing here in the US, but the problem is that this debate is going nowhere because nobody can agree on a common set of facts. And so investing in these data will actually, I think, move the minimum staffing debate forward. And as I wrote with David here in the piece, with better data in place, policymakers could break this stalemate and improve the care of millions of baby boomers who will receive nursing home care in the coming years. If you're facing similar issues in your countries, I would imagine investing in these data will help kind of make the case that, hey, we need more money in the system, or hey, we actually need to make better use of the dollars that are in the system. And by the way, both of those things could be true. It may take more spending, and we may need greater accountability. Final issue is about quality accountability. How do we regulate nursing homes? U.S. nursing homes are heavily regulated, but I would argue ineffectively regulated. I want to go back and think a little bit about takeaways from the pandemic. And there was a lot of debate about who is to blame here, in quotes, for nursing home outbreaks. Was this bad nursing homes? In which case, was this a regulatory failure that we just need to regulate those poor performers? Or was this something specific to particular localities or states, in which case we need to revisit how those particular localities or states are putting forward policies to address COVID? Or was this a national or system level failure in terms of how we regulate all nursing homes? And so this wasn't just about a kind of a bad actors problem, but rather a system level failure. So very early on, we wrote a paper led by Hannah Abrams, where we looked at which facilities have COVID outbreaks and which didn't. And back in June of 2020, the Wall Street Journal did a nice job of sort of summarizing our results and suggesting that the outbreaks were really about the large facilities, about where you were located, being an urban facility, and those facilities with more Black residents were more likely to have COVID outbreaks. It turned out it was much more about where you were located than who you were as a facility. We didn't find that the worst quality facilities in the US were the ones with outbreaks. We didn't find that those with a history of infection control violations were having outbreaks. It wasn't for-profit chains or those facilities with lots of lower paying Medicaid residents that had outbreaks. Once again, it was about the size of the facility, staff going in and out. It was almost a mechanical finding. It's very logical. The more people in and out in areas with high outbreaks, that's what led to COVID outbreaks in that facility. And it wasn't just our paper. We did a systematic review of this issue led by my colleague Tamara Konecka. If you can believe it, when we did this review, there had already been 36 studies published on COVID outbreaks and which facilities had COVID and which didn't. Maybe some of the folks on this call wrote these papers that we reviewed in this piece. But the punchline is that it was bigger facilities and it was areas with a high COVID-19 prevalence. If COVID was in the community around the building, it was in the building, given staff moving back and forth. This suggests that there are broader issues, broader sort of system level issues in terms of how we supported nursing homes, how we regulated them. This wasn't sort of a bad quality that we failed to sort of oversee quality in the worst facilities, but rather a system level failure. And that's really what we concluded. I mentioned that quote at the very beginning from that daughter with her parents. This is the document that we put together, that 600-page report. And our takeaway was that the way the US finances, delivers, and regulates care in nursing home settings is ineffective, inefficient, fragmented, and unsustainable. I don't think we could have been any more direct. We have a lot of work to do in the US in terms of reforming our nursing home system. When it comes to regulation, lots of documents over the years have suggested that we have a lot of gaps here in terms of regulation of nursing homes. What we recommended in that National Academies report went beyond simply COVID or went beyond infection control or identifying kind of the places with outbreaks and punishing them. It was designing a more effective and responsive system of quality assurance. So first, it probably won't surprise everyone here that we ask a lot of our survey agencies. We want them to monitor quality, but we underfund them. And so we have staffing gaps at our survey agencies. It's really rich that for years we've had nursing homes with too few staff. We also have survey agencies that are done at the state level that have too few surveyors. We also need to innovate on making the survey process better. We need to monitor data. We don't look at, we collect a lot of data, but we don't actually use this data very well in the survey process. We called for increased oversight of those worst performing nursing homes. If you're one of the worst of the worst, we should be looking at you more often. If you're one of the higher performing nursing homes, maybe we don't need to be doing a full survey in every cycle. And we also argued that the US has used what we call CMPs, or civil monetary penalties. That's been our go-to mechanism to punish nursing homes. I think there's probably other mechanisms that we might use, and even closing those worst of the worst. We need greater advocacy for nursing homes and oversight in terms of long-term care ombudsman programs. And going back to the prior point about kind of these owners and some of the issues that we've had with private equity and real estate investment trusts, we need to look at quality not just at the facility level, but also at the ownership level. you're an owner that's had a poor record of performance, we shouldn't let you acquire new facilities across other states and markets. Last slide, and then I'm really looking forward in our last 15 minutes together to answer questions and hear comments. But I really believe that we need to change how we regulate nursing homes, both here in the U.S. and, as I understand it, in lots of other countries around the world. I believe, though, this has to happen in conjunction with payment and financing reform in many of these countries. So if you're in Northern Europe and those handful of countries we always point to, you're doing great. But for the rest of us, we have a lot of work to do. And I think that work is really going to be at the system level. We can start with these incremental changes, but I believe the problem is much larger, and hence the solutions have to be much larger too. So I'm going to stop sharing here, and I can see Igor again, so that's good. And I'm happy to open it up for comments and questions. Thank you.
Thank you so much, David. And a lot of food for thought here, and I've already seen some questions in the chat. And I'm going to start just with a comment to say that I actually don't know of anyone in any country. I haven't spoken to anyone who say our system is really great, we don't need to change anything. So even the countries that we look up to, they're also facing challenges. And I'd say at the moment, particularly workforce recruitment seems to be an almost universal challenge, even in the countries that we tend to envy. One comment from me, and then maybe a question. So one thing that's looking at the experience of different countries in the pandemic, one thing that I found very interesting is that in Denmark, they've almost completely separated how you pay for care and for accommodation, in the sense where you don't pay for care because the care element, even if you're in a care home, is publicly funded. And so the provision of care in a care home doesn't depend so much on the real estate company who will have built the facility. And the way people pay for their care, so they pay for a care home, they pay rent for their accommodation, they pay for some of the services, the ancillary services, but the care is in the same way as you pay, as home help is organized by the public system. And that, I think, is a very interesting model, because it means that these issues of how do we raise the pay, or how do we change the ratios of different types of workers, are completely different if you're transparently paying for care separately than for the accommodation and the real estate side. So that was just so that float that thought. And I don't know if you have any comments on that.
I would so thank you so much. This is why we do these calls. I wasn't aware of that, but I would love to learn more, because that is something that I think the US system could really benefit from. You're exactly right. These real estate companies have taken an outsized importance in our system. And I've even heard many smart people say, these are no longer care homes, they're real estate companies. And that's totally upside down. And to your point, it's almost like a voucher system where we're going to pay for the care, whether you're at home, in assisted living, in nursing homes, but decoupling that. And I think it's distorted everything in the US, where we've bundled that setting, but we haven't bundled these other settings or unbundled nursing homes, such that we've underfunded care in these other settings. And so we've sort of pushed folks into nursing homes. And I think if we disentangled the real estate side of it, I actually think we could get some individuals out of nursing homes, because I think there's been that institutional bias. But we could also maybe get some of the smaller home models that we like, and some of the kind of innovation here that's been really lacking in the US system. So thanks for raising that. And I'm gonna read up on that, because there's something really interesting there.
And we have some comments from Josie Dixon in the chat. Josie, would you like to unmute, or if not, I can read them. Yeah.
You may as well read them, but hang on, let me just find the right screen. That was so interesting. Thank you so much, and so clear as well. I guess I just had a couple of things occurred to me. One was just the role of evidence. so there are these new regulations, and just kind of what evidence has underpinned them, like how have they been advocated for, how have they been arrived at, and then the transparency about financial ownership, equally blown away by that graph. Sort of sadly not surprised, but equally blown away. But just sort of wondered if you could say more about, because obviously that's quite complex, how if you envisage that would be used in the system, because I can see all sorts of, even if that data were available, which sounds like it's not very available, you know, complexities in terms of it actually impacting provision.
Yeah,
I'm going to turn my camera off if that's all right, but I'm totally listening.
Awesome.
I've got people wandering around. So
yeah, no, we don't want that. So first on the evidence, and I'm really glad you raised that, because this probably won't surprise anyone. There was an emphasis on having a report put together, kind of summarizing the existing research on staffing, and there was lots of emphasis on running some of their own analyses. Yet when those data, and they weren't perfect, but at least there was evidence there, kind of got put together with politics, that's where you get the requirements that we got. And so I think it wasn't that it was evidence free, it was that there was evidence, and then in some ways it was very selectively used in terms of setting up the regulations. And you wrote in the chat, why do I think LPNs were left out? That was just and it was based on these data, but very flawed data, and really disconnected from a lot of research that's been done and work in the field. And I think that was pretty alarming, and I think really ignoring the potential for unintended consequences, that you give the requirements to U.S. nursing homes to staff up here, and you can ignore here. You know exactly what they're going to do. They're going to staff up in RNs and CNAs, and they're going to ignore LPNs. And there's a lot of evidence that LPNs really matter, good empirical evidence, but also lots of qualitative evidence. And so you could imagine the political side of this. LPNs were not happy, and I think a lot of states were really worried that, wait a second, we've worked so hard to recruit these LPNs into nursing homes. Are we going to lose all these individuals back to other parts of the healthcare system? I'll pause there if you wanted to follow up with any of that before talking about transparency.
Thanks. I've got one from.
Let me answer her second question.
Okay. Oh, yeah, sorry. Yes.
Oh, yeah. Very quickly, she asked about financial transparency and how we expect this to be used. And the hope is that with those data, that regulators will use it, that consumers could actually even use this to say, hey, this is a private equity company. But ultimately, I think with the cost reports, we need that information such that we can follow the money and see how it's being spent, and actually come up with kind of real operating margins. Hey, this industry needs higher payment rates. Hey, we really should expect that you can staff at a level that's commensurate with the needs of these residents. This is not an unfunded mandate. There's plenty of funds in the system here. I will say, in a big concern, and maybe it's sort of underlying your question, is that we found in the U.S. nursing homes are often one step ahead of us. So we make this requirement, they do this. These companies are very clever in terms of how they set up their books. And so I've heard from a lot of folks that this is somewhat aspirational to say, hey, you're asking them to produce these related party transactions, and they'll figure out new ways of hiding money. And so I think we're going to have to be clever too. Go ahead. I think there was another question though. Go ahead, Adelina.
So we've got three. We've got only 5 minutes. So
okay, I'll be briefer. I'm being too.
We've got Leonid. Do you want to make the question yourself, or I can read it out? Okay.
Okay, thanks. It's a great presentation. Thanks, David. Lots of food for thought. A quick question. You seem to heavily rely on improved government regulation efficacy. And do you think about any substitutes such as community, relatives, civil society, grassroots oversight? Not necessarily instead of government, but perhaps in addition to government. Thanks.
Yeah, no, thanks so much for asking that. And we've had a lot of that. And indeed, we saw the opposite in the US during the pandemic, where family members weren't allowed into nursing homes for over a year, and care really deteriorated, partly because they helped to, feed their family members and bathe them and do part of the care production. But they're also the eyes and sort of oversight for their family members. And so that can't ever be the case where we're not having family members in there. And I think a big part of our report was needing resident councils at nursing homes, needing family councils, needing ombudsmen who are helping in a really important voice. But I think this is so complicated, and many of our nursing home residents don't have advocates. So the idea that we could rely solely on that, you're exactly right. That's complementary, but it's an important complement. Thanks.
Then Kai and Igor, and maybe you do both questions, and then David, you answer them all at the end, so it's okay. So Kai.
Yeah, so my impression is that you're running nursing homes like hospitals. I'm wondering whether there is any discussion about other stuff, because we know that large percentages of residents are, for example, having dementia and so on. So why is there this huge focus on registered nurses?
Yeah, and we need that level of care, but you're exactly right. We all too often, nursing homes in the US look and feel like small hospitals. That kind of grows out of a lot of the real estate. Once again, these buildings were built 35, 40 years ago. They're huge, shared rooms, long hallways. They're not pleasant places. We do have a movement in the US that's trying to flip that and sort of come up with these small home models like greenhouse. I know in the Netherlands they have the dementia village. Adelina and I learned about that last year at a conference. It's just really there's a lot of effort to do that alongside of improving the sort of care. But our ends are important, but you're right, they're no substitute for the quality of life here. And there's a lot of care needs for these residents, but we're also failing in terms of their quality of life.
Igor.
Thank you, Adelina, and thank you so much for the fascinating presentation. I just have a clarifying question. We see many similarities between American and English nursing homes and the problems they face. So my clarifying question is how often are nursing homes inspected by the regulatory body in the United States, and how often are low and high quality care homes inspected? Are there any differences in approaches, and especially during the pandemic? So regulators tends to focus on bad homes, putting a lot of pressure of them while overlooking other homes. So what's the situation in the US? Thank you.
Yeah, it's really a one-size-fits-all model where every nursing home is supposed to be inspected every 12 to 15 months. And we do that whether you're a high-performing or low-performing nursing home. And what we argued in that report is you could really vary that somewhat. And I think advocates are very excited about more regulation at lower-performing facilities. They're not willing to concede that a better performing facility shouldn't have a regulator in there also annually. They're just, but I think, in terms of resources and constraints, there needs to be some trade-off. Once again, we've underinvested in surveying in the US. So I see they're already saying thank you, and so I'll wrap up there and just offer my own thanks. This was a lot of fun, and these were great comments and questions. So I really appreciate it. Thanks again to Igor and Adelina for inviting me, and everyone for attending.
So thanks from me to David and for Igor. We're very happy to hear.